Starting, all right. Let's see who's here first. I might have to let people in. Nope. Right. Now they're rolling in.
Now, are most of these people patients or?
No, I don't think so. I've opened it up to our patients, but I've also opened it up to people on Twitter and LinkedIn.
Got it.
So it's a wild guess.
Now, are you at home or at your clinic?
I'm at home actually. This is my office.
Great.
Yeah, so I get to be divided from the family.
And have you been mostly, I mean, I've seen some of your postings with like your little quick 3-minute blurs, but that's at the office, right? When you're by a window?
Yeah. Yeah, we've recorded some of those in advance of COVID. All right, so it looks like we have 11 of us total. Should we wait a couple minutes and then?
Your call.
Where are you? Where's this in the background? That's your puppy?
That's the cage. Yeah, I have a pretty small house. Just where I'm pointing this way is sort of an open space, kitchen and the family room, and then a few bedrooms around, and that's it. The puppy's actually with my girlfriend. She might even be listening in.
Sounds good. All right. So let's kick off. I think people have waited probably long enough. And before I introduce you, I guess I should let people know that we have a chat function, and if you want, you can type out questions if you have them. If you'd rather talk, there's a raise your hand function. If you raise your hand, I can click to allow you to talk, and you can voice your question. I generally don't read the names of people who are asking the questions, just in case people watching the video later either don't want to know or someone who's asking wants to keep privacy. All right. So I guess without further ado, we can start. I'm not thinking this will be super formal. I think we can just to some extent talk, and to some extent, I'd love to have you share, who you are and what what we're doing here together in terms of pediatrics and trying to bring some knowledge to the world.
No problem.
You can hear
me fine, right?
Yeah, no, it's perfect.
Okay.
All right. So why don't you tell everybody a little bit about you and what brings you to medical cannabis in pediatrics?
Sure. Well, again, my name is Eric Exelbert, and my everyday job is a pediatric intensive care physician. I work at a hospital down here in South Florida. The city's Hollywood, Florida. I've been down here this is my 11th year, and it's about my 15th year or so outside of all my training. And day-to-day function is in the intensive care unit for children. It is not the neonatal intensive care unit where prenatal or premature babies are born, or newborn babies, but pretty much from the time you're born and till the time you're about 20 years old. And pretty much all the kind of children most people don't want to see or take care of because they're ill are in our unit. My cannabis life pretty much started when I finished fellowship, which I did in Denver, Colorado. And it was around the time I finished in 2006, and between 2006 and 2010 was when cannabis was beginning its journey, if you want to call it. And Colorado, as everyone pretty much knows, was at the forefront of that. So within the time of you being allowed to, people being allowed or getting licenses to grow plants, it seemed like within a year there were pop-ups everywhere if you had a card. And then I moved in 2010, before it was recreational. So I sort of was getting my curiosity piqued. And of course, unless you lived under a rock, cannabis is, part of anyone's, life, depending on what sort of social group you're in and where you go to school. And so my journey really was, as states were were beginning to adopt medical cannabis. Florida was sort of on that journey. And in 2016-ish or so, things were coming to life. And I wanted to figure out a way, as this was coming into the forefront, of how I could make this part of not just my knowledge as a physician, but how I can bring that into my medical career. So the difficulties really took place in the fact that I'm in an intensive care unit. I work with pediatrics, which always was controversial. And I also am in an in-hospital setting. So everyone just sort of had to buy in. So what I ultimately did was, there was a CBD company, a hemp-based CBD company that was out of South Florida. And I really reached out to them to see if they would help some of the kids who I thought would benefit from some type of therapy. And there really weren't any options. At the same time, I started getting a licensure because that was necessary for me to do anything here in South Florida. And ultimately, the only thing I could do at that point was to leave the hospital setting, try to open up my own clinic as I became certified, and I'll spare all the other political details, and basically spent my days off driving around throughout South Florida. And I took advantage of learning from patients who sought me out. Most of them were referrals from the hospital. And then ultimately it got busier, and driving is not the best way to have a practice. And so I was renting space in various places, and basically my out of hospital life became my medical cannabis life, mostly seeing complex pediatric patients, and would also see adults. And that sort of was the 3-year journey up until November of last year.
Awesome. Thanks for sharing. Do you have particular rewarding experiences you faced, or time when you're educating others with cannabis, things that you look back on and think, boy, this is really why I'm doing it?
Yeah, I think I think that from a non-patient scenario, I would just say that for the first time this past fall, I'm on staff at one of the medical schools here, Florida Atlantic University, and I've been lecturing there since 2010. And it was always pediatric lectures and ICU lectures. And I've been begging them for the last 3 to 4 years to adopt something in relation to the endocannabinoid system.
Great.
And finally in the fall, again, this is a non-patient interaction, but was able to give the first lecture at that medical school for first-year medical students it was a 1-hour lecture on the endocannabinoid system. And that was just encouraging from a medical education standpoint. The first few patients that I saw, I would say, because of where everything was mostly related to brain tumors and refractory epilepsy or seizure disorders. And so I would say that probably the 3 of the first 5 patients that I ever saw were some of the most rewarding. One patient had an inoperable brain tumor. He was a teenager who had really never been able to leave the house. He had horrific hallucinations secondary to his brain tumor. It was inoperable, as I said. He had terrible morbidities associated with his disease related to steroids, but he couldn't leave because of the hallucinations. He was scared. He really became much of an introvert. And so mother had tried tons and tons of things. And to make a long story short, he ultimately ended up on, at the time, basically what we were able to give him was CBD, and he ultimately got a medical cannabis card. And not only did his hallucinations improve, they never went away, but fast forward to about 2019, he was back in school. He was able to go to games and get out in public. He got in shape. He lost weight. He was off most of his insulin that he had gotten from steroid-induced diabetes. He was relatively seizure-free, and his tumor, at least by radiographic, imaging, was stagnant. So that was more of a symptom management and a prolonged management, and really started off as palliative care. And this is a kid who's now a teenager and was quite functional. I would say the other one would be on the other side of the spectrum, for a child who had one of the, I believe she had Dravet, if I remember, Dravet syndrome, which is one of the indications for Epidiolex, which I'm sure we're going to talk about, but basically known as a fatal epilepsy syndrome. not only was this patient had a fatal epilepsy syndrome, but she also was on a ventilator. And part of the problem that she needed from being on a ventilator was that she was always sedated, extremely sleepy from 4 to 5 anti-seizure medicines. So to just fast forward, within a year, her 5 medications were down to 2. And within a year after that, and it could be true and unrelated, but she was off a ventilator, although still had a tracheostomy. So this is a patient who would have died in most normal circumstances. And then B, not only was still alive, but actually had improvement. And the mother's goal when she came to see me, because it's always goal-directed therapy, was that she just wanted her more awake. And more awake led to these things. So I would say, those were 2 of the early ones.
That's inspirational.
Those are probably the most.
Yeah. Awesome. Actually, so there's a question already in our chat, which is about using hemp-based products, meaning less than 0.3% THC, like Epidiolex, or do you prefer THC products in chronic pediatric pain or sort of chronic patients, or does it depend more on indication and individuals' kind of circumstances?
Yeah, I think it depends on the indication, of what it is. I mean, I always try to teach the families, and I'm sure you do the same thing in terms of semantics. I would make the guess, although I'm not willing to bet on it, that most of what we call hemp is probably coming from marijuana, as you know, and it's just because it's less than 0.3%, they're able to call it hemp-based products. I think that my safety, to be honest, and again, it depends on the diagnosis, is if you believe in the entourage effect, which I think most people in our world do believe, that we should be getting as many of the cannabinoids as we can. Because of the way the different states are set up, you're sort of limited, especially in pediatrics, without the ability to get flower, or without the ability to get all of the cannabinoids. You're really limited to saying either pretty much all CBD, which you would call hemp because it's less than 0.3%, or THC oil. I will say that I think, it really is what you can get at your disposal. I think having some THC in there, again, for the types of patients that I would see, I think is helpful. The more cannabinoids, the better. And as we're learning, and I'm sure, again, we're going to talk about it, as to what's best for everybody. But again, some of it would depend on the parents. Some of it would depend on the availability. Third would depend on if they had a card, because obviously you're limited if you had a card. And fourth would depend on if you have a reputable company, depending on where you're getting your product from, as to knowing what you're getting. So the more the better, I guess, if I could call it. But again, just depends on what you can get.
Yeah, I agree. I think my take with the, is it just CBD for kids story is, first to take a step back, and is the aversion to THC because we're dealing with the devil's lettuce? Is this a sort of misunderstanding of the evilness of cannabis? And God forbid our pediatric patients would experience joy. I mean, there's something sort of wrapped in mystery and evil about cannabis, which is totally undeserved and unrealistic. I think the irony is, chemically, and obviously but for our audience, chemically, THC does have receptor binding in the brain. CB1 receptors are activated by THC. That's not the case for CBD. So actually, if the audience were better informed, they could make a good argument, actually, that, wait a minute, while we don't want some kind of brain defects happening with THC, I mean, of course, that's not the case, but just for the sake of discussion, one could make a good argument that CBD would be better for children because of that, if people were aware of that. All that aside, my take is really, just like you, it's an individual circumstance. I think the fear of THC in children is mostly unwarranted. We're not talking about, and maybe I should have started with this. We're not talking about normal children. These are not kids, playing in the playground and we snatch them and give them cannabis. These are patients who have been suffering through intolerable illnesses that no child should ever experience, and they're going through agonizing treatments, whether they're in the hospital or in their homes. These are just absolutely suffering scenarios that we are relieving with cannabis choices. These are parents who are at their wits' end, Um, and we're offering relief. I mean, we're not, you know, it's a very important thing because I think a lot of people imagine when we talk about children in cannabis that, oh, it's the kid at the park down the street, and it's not that child.
Right. I think that's hugely important, and I'm so happy you said that, because I was going to even start the conversation with something related to that. I mean, yes, these are children who exist under the medical system, who exist and have been seen for whatever that might be, and are for the most part on a lot of medications that actually there is data that there's deleterious effects.
Mm-hmm.
And yet we as physicians, I mean, I'm in the ICU. I mean, I just today gave a medication that is going to be used for a horrific type of kidney disease, and the parents didn't ask any questions.
Yeah.
And even though we discuss it, and even though we talk about the side effects and everything, their child, or they want to see their child get better.
Just
and
keep them alive. Right.
Yeah. And then you go to the flip side, and these parents have been dealing with, just like you're saying. And so if you sit down, at least for me, and educate these people, these parents, and it's just like educating a medical student, you're really doing the same thing in layman's terms. I don't even think that we as physicians are doing that when we're going to start a blood pressure medicine, or when we're going to start, these anti-seizure medicines, and yet all they want is help.
Mm-hmm.
And I think if you explain those things to them, and you show them what receptors are, that they're, just like doors that open and close,
Mm-hmm.
and you show them what's happening, it actually not only becomes fun, but it also opens the door that this is real medicine that exists, and actually is probably going to have less side effects than the medications that they're on.
Right.
Now, this is not little Johnny who's coming in for his well child check at 5 years old, and mom says, he didn't do well last week, and he's been getting up from his seat. We're not giving them, a cartridge. So. Right.
I mean, it's funny. You and I laugh about it, how ridiculous it is, but I think that really is the sort of politic kind of discussion that, like, they're just completely off the deep end of, as far as yeah. So someone posts that the stigma is real, and that's really what it is. It's just cloud of misunderstanding.
Yeah. And I think, that I would say the most common thing, and I'm sure you deal with this every single day, is I don't want my child to be high.
Right.
And I look right back at them and say, we don't want your child to be, high either. But there's nothing, when you have a sickle cell disease patient who's going through a sickle cell cream crisis, it's sort of okay for them to be high on their morphine because
Mm-hmm.
the pain is getting better. And so that's okay. But it's okay for them to get horrific constipation and maybe develop a bowel obstruction. And that's
with the morphine, just to be
exactly.
clear.
And that's a different type of stigma, but yet the stigma that we're talking about exists, unfortunately. But that's where again, what I've really enjoyed about medical cannabis
Mm-hmm.
or just the endocannabinoid system is it's gone back to just the basics of teaching your patients and us all learning together, because I'm
Mm-hmm.
learning as much from them as they're hopefully learning from me.
Mm-hmm. One of these talks in the past, we interviewed, or we had a discussion with a rabbi, and one of the points of that discussion was, when someone asked this rabbi, I don't want to be high, or do I have to be high? He actually confronts it face on, which I really admired. The way that he said it was basically, why? What is your concern with someone feeling euphoric, feeling joy? What is so terrible about that? This is someone who is suffering immeasurably. Even if it's someone who's stressed out because COVID is creeping in from all sides, what is so terrible about them feeling joy that's not real?
Yeah.
And I think that's remarkable. I think I understand really what's behind the question for parents, and that's, I don't want my kid to always be high. I don't want them to always be out of touch with reality. But that's not what we're talking about. That's not everyday stuff.
Right.
All right. So someone posted a question, which is, how do you dose cannabis in pediatrics, and is it safe?
Good question. So I think we all, I think there's probably not a person who's taking care of medical cannabis that doesn't feel that their way is the right way. And to be honest, even though I have, and I'll answer your question, it's sort of a dosing regimen, if you want to call it, or a protocol. my goal is to just not overdose them. Not that the overdose means that something terrible is going to happen, but give a dose where you've superseded what we think may or may not work. My rule of thumb was that I basically, for anybody, and I'll take you through my story of how I got to this, is in the state of Florida, when I started doing medical cannabis, it took a while to get your card. And so because of that, there really was only one choice when you would originally come and see me, and that was buying over the counter a hemp-based product. Again, let's call it a hemp-based product with, you know, with pretty much CBD. And so I would take advantage of that 4 to 6 weeks, let's call it, to get the card, and I would start on CBD. And the way I would approach it then was, I think, because that's what people were doing, was I would do roughly, you know, depending on if you use pounds or kilograms, but let's just, you know, call it somewhere between 0.5 to 1, because a pound is, again, give or take half of a kilogram, milligram per kilo. And I would try to get them to do it 2 times a week, excuse me. And I would sort of work my way up. But really the reason why I started low and the reason why I had a milligram per kilogram was because I required, and I know you do the same thing, that the families would have to get back in touch with me all by email and basically send me a diary. As opposed to if I was treating someone for blood pressure, I'd wait a month until I saw them again and take a blood pressure and hope. I mean, I wasn't asking somebody to send me their blood pressures every single day, you know, but that's what I sort of was doing.
Yep.
And it would do a few, and then I sort of would limit that up to about, and I would always ask if they were marijuana naive or, just because I think it's just important to bring that into the mix. And then when I got to about 25 milligrams as a starting dose, meaning per weight. So if you were, let's just give an example, if you were 50 kilos, so to speak, and we started at about, I would sort of make that, I wouldn't ever go over that, you know, so if you were a normal 60, 70 kilogram patient, I would start there. And I would take that opportunity to go from there, and I would increase no more often than every week. And again, depended on what the circumstance was and if there were any effects. So that was how I originally started, because that was, you know, the only choice I had. Just before I became medical director of one of the companies, when I was seeing patients, the speed was much better, and we were able to get cards relatively quickly. And so, or patients were. And so at that point in time, if depending on either the circumstance, I would then start adding, 1 to 2 milligrams of THC. And that was really not specific to kilograms, to be honest, unless they were a baby. And then it just depended on what their diagnosis were or how severe the symptomatology was. So that was sort of my rule of thumb. I think if there were patients that were on, if someone came and saw me for pain, and I think that's a whole nother bag of worms, who were on a lot of narcotics, then I would start things a little bit differently, because the goal was usually to acute pain and to get off narcotics. From a safety perspective, I think what we all think we know, the biggest safety things that I worried about was what other medications the patients were on. And at the time, and I would still say that it's probably relatively consistent, there was one epilepsy medication, clobazam or Onfi, which was sort of known for, because of the cytochrome P450 and how it was metabolized, that it increased those levels. So all of those patients, in conjunction, we haven't even spoken with how I would work with their primary care and subspecialty physicians, but we would right off the bat cut those doses down by about 10 to 15%, sometimes even 25%. And then there were tons of other medications, to be honest, just like if you were on an antipsychotic and an antidepressive and a benzodiazepine, like Versed and Ativan or Klonopin for the listeners, we wouldn't exactly know what to do either. But again, by hopefully getting my patients to email me and call, whatever that might be on a once or twice a week basis, it made it safe to me, or feel safe to me, because we were doing this together. And they wanted to reach back to me just as much as I wanted to reach back to them, because it was immediate results. We were really getting to see what was happening before our eyes without me even having to see them. So that made me feel like what we were doing was safe.
Sounds good. One of the things that you bring up is sort of adversity and risk. With clobazam, for the folks who don't know, basically the story is when clobazam is on board to help fight seizures and cannabis is on board, they sort of amplify one another. So if you had a dose of, X for clobazam without cannabis, it might boost up to, more than X or twice X or something. So there's concern about a safety level of that medicine. Just to translate the doctor speak. What have you seen as far as uncomfortable experiences or unpleasant effects from cannabis? Things like side effects, but also maybe difficult discussions with parents. What's been your experience?
Yeah, I think that there's three things that come to mind really quick. We are obviously limited by the mode of administration that we can do in pediatrics. I'm just going to specifically talk about pediatrics right now. And again, the majority of the patients that I would see were relatively ill and complex. So the first thing I'll tell you is, or I'll say is, was taste. So if they were taking an oil, or if we were attempting to get them an oil, which really was the only way to go for the majority of the time, depending on the diet, but let's just take pervasive developmental disorder or autism as an example, who have very heightened sensoriums, don't really like interacting, depending on how severe that is, but taste or food or eating is a big deal. So that became very, very challenging. And how would we get that in? Same thing with having a gastrostomy tube is, you would think, well, then that's no big deal. But most of these, not most, I would say, you can correct me if I'm wrong, but probably above 90% of these products are in an oil-based, whether it's MCT, which is medium chain triglyceride, or coconut oil, whatever it might be. And so there's always this theory that oil-based products can get stuck to the gastrostomy tube, and how do you get all the product in? How do you know you're getting what you need? So, I mean, those are sort of the technology, or the system-based problems that were the biggest deal. The other two things that were always challenging, and again, I'm going to stick with pervasive developmental disorder, because I find those patients very challenging, again, depending on what side of the spectrum you're on, is that I would get calls when I'd say I would get more times than I felt comfortable with at first, of calls from the family with after the first or two doses that it made the patients worse. It made their behavior worse. And it was always hard to tell, was it the behavior of the patient? Was it the CBD? Let's just stick with what was going on. But what I did find, and I think with talking with a lot of other people that have been doing this, is that low doses of cannabinoids with those patients actually were really deleterious in terms of their sensorium, and you had to sort of crank those doses up relatively quickly, or add THC if you had that at your disposal a little bit faster. Those were very, I think the challenging part was hoping that the family could believe in what you were trying to do, and vice versa, and getting through that. And that's just a hard problem to handle. And then I would say in some of my adult patients, which always surprised me, is there were some adult patients that were convinced that just with CBD, not convinced, but really felt high on just CBD. And I at first wanted to believe and say no. And because this is what we teach, this is what we learn. And for all the reasons at the beginning of the conversation about where CBD, affects and how it works. And because it usually is not, a direct stimulator of these receptors. But I think that there are people who are just very, that I think the endocannabinoid system has an effect, gets affected. And for whatever reason, what they feel, I have to believe. And so those people, either it doesn't work for them, just like somebody who tried marijuana, it doesn't work for them, and that's just not something that they should do. Or we needed to, or maybe they had a strain, or maybe they had a chemovar, if you want to call it, that just for whatever reason didn't work for them. So I was always surprised at first when I heard that, but I think it was, I would hear it. I'm not going to say statistically significant, lot of people, but enough that I had to take that, more than just a grain of salt.
One of the things that is not well understood by most people is part of the system in our bodies which takes apart cannabis for disposal. Once we take it in, it doesn't just live there; it gets destroyed and gets trashed. Part of that system, obviously speaking to our audience, Eric, part of that system is inhibited by CBD. And so, I sometimes bring the example, there are people who are curmudgeon-y people. They're not happy all the time. They're sad, or they're whatever, melancholy, whatever word we use. Then there are people who are naturally very giggly and very happy, almost as if they're naturally high. And I think if you give CBD across the board, you're going to find probably someone who's naturally very giggly or has that in them. Maybe they're more likely to feel more giggly or high. And partly that's because of the inhibition effects of CBD on the degradation molecules. I don't know. I think also to add to what you said, in addition to the chemistry of the cannabis, there's also the environment. And, these are parents who are giving their severely developmentally delayed or dysfunctional child brand new medicine. And there's probably some anxiety around there, and it's probably a tense environment. And kids are, if nothing else, very sensitive to the environment and can pick that up. And maybe these children were responding to their environment. I mean, there's so many things which could be involved.
Yeah. The only other thing I'll add, which I think I'm glad you brought up, is I'm completely convinced, and I think that this is more from personal trials of different CBD products myself, and really wanting to understand and be aligned with my patients, is I know personally that depending on my hydration status,
right,
and depending on what I've eaten, if I had a fatty meal versus a non-fatty meal, if I woke up at, a little dry or a little, or just worked out,
mm-hmm.
that you can have with the same dose, same company, or, whatever that might be, can be completely different.
Mm-hmm.
And, that's to me that, what we're learning now, or hopefully
mm-hmm.
going to learn now.
Mm-hmm.
And that whole first pass effect, like you're talking about, and some people can break down, and the byproducts of, especially, the different, THC byproducts that,
mm-hmm.
some of them can be even more stronger than the others. So
mm-hmm.
that's, I think it's real. I
mm-hmm.
agree with you.
Yeah, right on. As an ICU doc, you've undoubtedly seen pretty intense, horrible cases of very, very sick kids, and children who are horribly faced with unnaturally early death, and the process leading up to that. What are your thoughts about cannabis in the context of palliative care in pediatrics?
Yeah, I'm going to be very honest and say that I'm very biased, because our palliative care team at my hospital has completely bought in and really has used me as a guide. I would just call it another piece of the pie of their armamentarium.
Mm-hmm.
I think as either, again, most of these are going to be adjunct therapies, but from a side effect profile, from a potential to have calmness or to be calm. I mean, I get the answer to your question is I think it's underused, and
mm-hmm.
it should be used, as much as possible.
Mm-hmm.
When we're talking about these types of conditions, I think that, and I watch it every single day, giving high doses of benzodiazepine against Versed, Ativan,
mm-hmm.
to just basically make someone as calm as possible and sedate them to the point where they're not awake. Even though everyone should pass or go through the end of life with dignity, I think we can do it better. So I think from a palliative care standpoint, and in pediatrics, again, we're going to be limited to the things we're talking about, but I'm waiting for the days where we can IV infuse cannabinoids. They're probably doing it in some parts of Israel and Europe right now, but it's completely underutilized. I think it's important. It's
mm-hmm.
beneficial.
Mm-hmm.
I hope that it continues. I mean, in our world, what usually happens when I get involved is I'm usually used as a last resort, where can we do this because we've done everything else.
Right.
And especially in the ICU, I mean, my dream is that someone comes out of a painful surgery, or someone comes out of a horrific surgery, and who's left with some catastrophic, damage, and I'm able to, give them these right off the bat. I believe that will be the future. I think it is. But I think it in palliative care is completely underutilized, and it's at least it's done down here with us a lot.
Let me fill in some background to what you just said. So when you're saying you wish, in these severely traumatic cases that you could bring it right as a sort of first line idea, or first line treatment. Underneath that, supporting what you just said, is a wealth of data that shows from actually post heart attacks that CBD on board can actually help the tissue heal more quickly. For strokes, so when there's a blockage in the brain and brain is dying, that the presence of cannabinoids actually helps the dead area become smaller, or make less of a dead area. So it seems like in traumatic scenarios, the sooner cannabinoids are involved, the better these folks are doing.
Yeah.
Yeah, I think a lot of people are aware of that.
Yeah, I mean, you bring up a great example. I mean, I'll just give in someone that suffered a traumatic brain injury, let's just say from a car accident, they were hit. So unfortunately, we have, kids that have suffered what we call non-accidental trauma, or even someone that had a horrific brain tumor, but, had damage that was done to that. We have things that we shoot for in the ICU. We like to keep the sodium higher than not. We like to keep them a little dry, if not. But the physiology or the reasons we do all this is to try to save the good brain, and to try to prevent the deleterious brain, or the brain that's died or gotten worse, from causing problems. And what frustrates me is that we have, again, a lot of it is in vitro data, meaning it's in the lab and it's in the cells, of the anti-inflammatory effect. And if you can, and then if you throw in that we're also placing these patients in a medically induced coma, that we're, again, using all these other sorts of medications, to me, this is the tip of the iceberg, and it's like the perfect cocktail. I just wish that I'm infusing some, oil-based product that, not oil, but something that we can put into the, the IV. But those are exactly what, what we, I think, can do in those environments.
Yeah. I mean, we're on the same page, sort of obviously about the palliative care. I think actually I would take it. I tend to take things on a little bit more of an emotional curve as far as doctor to doctor is concerned. I think it's unethical, actually, for doctors to not be knowledgeable, and they don't have to be prescribing things that are recommending things that are making them uncomfortable. But I think it's unethical for them not to know, and not to be encouraging patients to learn for themselves. I think one of our jobs as clinicians, as opposed to research doctors, when we're interacting with people, is to make sure that they're doing what's best for them. And that's always them. That's not necessarily what's best for me as their doctor. Right. And that's a hard thing, I think, for doctors these days to really wrap their minds around. Yeah. Or at least I'm not seeing it as much in practice. So we have a question here that's a really great one. Do you often run into disagreements with your pediatric patient's primary care doctor or specialist about a difference in treatment plan? Have you found that they support cannabis or not?
Yeah. So again, I'll preface this with, I've been very lucky that in the past few years, I would call what I had a concierge type practice, meaning that I really never had to market or advertise, because South Florida, from a pediatric intensive care, even though we're a large population, there's not a lot of us. And there was not a lot of me, meaning seeing, at least advertising themselves to see kids. So when people would get sent to me, there was a reason. And I would be getting sent by physicians. And again, it's probably the same in Massachusetts and other places. You needed to have two physicians consent anyway. Mm-hmm. So that was a little less of a problem. However, when patients seeked me out without letting their primary care doctor know, and then I would reach back out to them, there was a very high incidence of unhappiness, if you want to call it. And the way I would approach it is probably just like you and everyone else. I'm not here to take your patient's care over, but your patient did come to see me, and it is my responsibility to talk to you about why they came. And then I would offer to come to their office and give a lecture and talk to them, or just meet them. Again, a lot of them I knew, and really just try to, teach them like you and I just talked about. There were some who, of course, would be absolutely not. And then I would look at the family and the parents say, you ultimately have to make a decision. I can't make that decision for you, but you are free to purchase again, over-the-counter hemp-based product that I think might be reputable, or that I've tried, or that we've recommended, we've had tested, and then we go down that pathway. I think the subspecialists was probably the most difficult. Again, a lot of subspecialists would send, those patients to me, but you're in Boston, so there's a lot of competing hospitals, and I was doing my clinic not as I work for Joe DiMaggio Children's Hospital, so not as a Joe DiMaggio Children's doctor. And so I needed to let them understand I'm not trying to steal your patient to come to my hospital. Again, they've reached out to me.
Yeah.
But I think over time, the doctors really weren't left with a choice because the patients were demanding this. And so you can either ignore it or those patients are going to leave. And so my response is that I think that 75 to 85% were right on board and understood. And I think the second step for me, and this is not an ego comment, but I do see the sickest of the sick patients every single day. And so it's bread and butter to me, meaning when they come, I understand the disease process. And I think that I wasn't somebody who just was interested in starting medical cannabis and started this clinic. And, I might've been out of practice for a long, time. This is what I do every day. And I was, an arm in their armamentarium. And so I think that helped as well, in my situation.
Well, it's really interesting because I actually come from the opposite end of the medical world where I'm, you're a master of very acute illnesses and very severe illnesses. And I'm more of the surveyor of what's common in the primary care world. And I think the fact that we both come to cannabis with such passion and appreciation is really telling of cannabis as an entity, as a medicine. All right. Can you speak to the medical literature? Are there enough studies for us to feel safe with medicating our children with cannabis? What are your thoughts about it?
I mean, I'll come right out the bat and say, I would say there's not enough data in the sense of that's consistent, good, prospective, randomized data, right? I mean, that's what we're supposed to say. However, I think that I believe in terms of the safety profile that the downside is minimal and the upside is massive. I think that there's enough data out there that that the use is prominent. And I think that the types of patients, again, we started the conversation off like this, the types of patients that we're seeing, I think that there's, to me, enough data that the benefit outweighs the risk. The problem, as you know, is that the data that's out there has been either very, very low amounts of patients. They've been, I just, wrote an article for the American Journal of Endocannabinoid Medicine that's coming out, and it was basically a study that they tried to subpopulate all these patients with tons of different types of diseases and then come up with one CBD milligrams per kilogram based on a Dravit, based on the Dravit Lennox-Gastaut study using these completely other types of patients, and it's not applicable. And so I think that I think that there's enough out there that I feel safe. And I think, to be honest, that, there's a lot of basic science data that's out there that explains the endocannabinoid system in different disease processes that is very important. For instance, you can go to PubMed and you can type in systemic lupus erythematosus and the endocannabinoid system, and there's beautiful articles on what's wrong with their system. You can do the same thing for name it, and that's out there. And so for me, that's the ticket. And then if we start populating these patients and then hopefully get products that are consistent. And so I think the answer is yes. But the kind of studies that we all read all the time and that becomes sort of the gold standard of medicine, has not been done.
Yeah, I agree.
Quick answer.
Yeah, I mean, we could really go forever, but I think as far as literature goes, there is a ton. As you said, there's a ton of bench science. We understand the chemistry very well. We have applied that to animal studies and have, a reasonable understanding of what's happening in an animal environment. most importantly, we understand the safety profile. That's I think for doctors who are very conservative or not knowledgeable, that's a worry. Is this safe? And I think once we see that it's safe, as we were alluding to earlier, let's not take it in a silo. Let's compare it against the things that we're giving all the time. And really it's not even in the same ballpark. I mean, it's so much safer. It's so much more well tolerated, and the potential positives are so much more frequent, so much more real. Of course we need more studies, and not a lot of people are aware of there's a bulk of literature which was funded by the National Institutes for Drug Abuse. I think most people are familiar with cannabis having a target on its back for social and political reasons, mostly racism, and from the 30s up to the 60s. But that's true in the science too, that there was this agenda, just as there is today. Actually, your ability to teach in medical school, you had to push for that. I mean, the medical schools are still not teaching endocannabinoid system or cannabis from any positive light. That's today. I mean, in 2020, it's crazy. But anyway, I think to some extent there is enough research to make educated decisions for a clinician. That's what we go to school for, is how to learn and how to make decisions based on scant information. On the other hand, it's safe, and I think that's one thing independently. But really, it's about the patient in front of us, and it's really not about us as clinicians coming to the scenario saying, is this safe? Do you want this? It's about the patients and making sure they're educated with this. Okay, we don't know that much about it, but everything we see is pretty good. And let the patients come to that decision. I think it's really not so much about us. Okay, so let's move on. We have a question about Epidiolex. Is this something you use in the hospital? Have you seen good results with it? How would you compare that to CBD isolate? And then someone else was asking about CBD sort of whole plant extracts. What are your thoughts about Epidiolex, isolate, and full plant stuff?
Yeah, so I'll talk specifically about Epidiolex. I'm going to try to not be biased because I'm very frustrated with the Epidiolex for, obviously there's the monetary concerns in terms of what the drug costs when you can get a reputable product for pennies on that dollar. My fear and what I've been seeing with that. So, and let me back up. The other thing, which some people may or may not care, but if you get a certificate of authenticity on Epidiolex and you look what's in there, there's actually a high percentage of alcohol base that's in there. So again, parents should just know, because, just like they're worried about a child getting high, again, a lot of medications, have different types of alcohols in there, but there's an alcohol, that's in the base, and it's not a small percentage, but it is there. So in terms of just what's making up the Epidiolex, but I think the most important thing is that Epidiolex is now being instituted by a lot of neurologists, which I'm happy about, but the dosing that they're using based on those studies that we were talking about earlier on are ridiculously high, meaning that those are sort of the end of the spectrum, worst of the worst type patients. And I'm not sure how applicable that is to the run-of-the-mill seizure patient whose families are interested in Epidiolex. Granted, it's indicated for only those two situations, but I think that there's been ways around doing that depending on your insurance. So I'm happy that it's out there because I do think it's forcing clinicians to learn what it is. The fact that it's advertised as pharmaceutical grade, just helps that people think that it's, the best of the best. But again, just like we've talked about, it's one cannabinoid, just like we're all stuck with one cannabinoid. In terms of the whole plant extract versus just an extract, I think the education that I would tell people is, those words are really used, at least in my opinion, as to how it's extracted from the plant. What type of processes does it go through, even though those words should mean a certain thing in terms of just getting that one specific cannabinoid or the whole plant and get everything from there. I mean, again, my bias is that, the more cannabinoids that they can get, the better. I still feel like I'm learning about what all the different cannabinoids do and what works best for everybody else. So, I would say if you're extracting one particular cannabinoid, I think it's very important to just understand how that process took place.
Mm-hmm.
What did they use to extract it? How did they use it? And then if that seems to be, safe, then I think that that's okay.
Mm-hmm.
If the whole plant is what you're getting, so to speak, then you're going to get more cannabinoids, and then you just have to ask yourself, well, what does 0.5% of CBN mean versus 3% of CBG?
Mm-hmm.
I don't know what that means yet, but I'd rather it be in there than not be in there, I guess.
Yeah, that's how we learn. I think one of the important things to raise here is, if we take a step back and look at some of the studies that have been done, JAMA did a really interesting study that was basically looking at the truthfulness of advertising from CBD companies. Are they selling what they say that they're selling? And the punchline really was that they're not quite right, that there's some difference. There's the big discrepancy between what you think you're getting and what you're actually getting. And if you connect the dots between that reality and the fact that lab testing in almost every state samples a very, very small amount of the cannabis that is being processed and sold, and then connect that dot with the fact that in a cannabis plant, what's up at the top of the plant and the bottom of the plant might not be the same thing. There's so much wild variety and variability inside each cannabis plant, and certainly across multiple plants. There's so much variability that when you're not testing perfectly, which is testing more than just 10%, maybe 10% is hugely generous actually, that you're going to end up with those kinds of variables. So is a whole plant really a whole plant? Is a isolate really an isolate? I think so words matter. And to your point, isolate, when it's sold online, is not always from a plant. Usually, well, maybe once it was from a plant, but sometimes it's also filtered through chemistry so that it is only one compound. It is CBD across the board. There's nothing else there. But then there's also isolate, which is, it's mostly CBD. And there's no good system of testing yet. I think some people get scared by this sort of uncertainty and these problems, if we call it that. I think it's a little bit of nature's force, nature forcing us to be humble and to say, look, we don't have control over this pharmaceutical. This is not your average Joe, and we have to step back from thinking we know everything and be open to learning and figuring it out with our patients. And I think it's going to help medicine. I think it's going to help the practice of treating people, that we're forced to listen and see how this person's reacting with that product. And if that's not working, let's try something else. I mean, it's the same thing we do with regular medicines.
Yeah. I used to say that, and I still say it, but that, we've sort of gone excuse my language, half-assed backwards with what's been going on with cannabis, because, we've been taught that a drug gets trialed in X amount of patients, and that's your phase 1 trial. And then really to look for if there's any side effects. And then you go through phase 2, and the cat's been out of the bag now since, California started. And so now we're sort of stuck answering exactly these questions that you're talking about. But what I do think it's done is exactly what you're saying, is it's because there's such this concern, and because there's so much propaganda, and people, we can go on whatever social media that we want to be a part of, are on both sides of the fence. It's like the political race, what's going on. You have people on the other side of the fence, but it's forcing us to learn, and so that we can make better decisions. And what I love about it, especially in this world, is it's forcing the patients to come to us and ask really good questions, where it's gone back to where we can say, you know what, I don't know. And the ego is gonna can get dropped, which I think is very good for us modern physicians. Yeah. So that part at least makes me feel better that, when I used to say the cat's out of the bag already.
Right. No, I agree. Actually, so there's another question just came up that kind of launches right from this. Do you think it's realistic for parents or pediatric patients to be able to comprehend all the information about cannabinoids, and have enough sophistication with the extraction methods and all the rest? How can we make it more understandable for patients to basically avoid the stigma, or at least try to chip away at it?
Yeah, I'll give an example. You know, one of the things that I've always loved about not all, but a lot of the pediatric heart surgeons is that
Mhm,
they need to draw the lesions that are going on with the patients.
mhm,
I've been doing this for a long time, and there's not a day that goes by that I still have to sometimes look something up and be like, wait, where's the blood going? Or, or what's going on at the bed, and trying to figure it out. And what do? We go back to the pictures. We figure out where the blue blood's going. We figure out where the red blood's going. We figure out where the shunts are and what they needed to do. And that's what we show the parents. And, you know, I never in my training, or never when I was a resident, and of course I'm in the ICU, did I carry around a big book. I probably have it underneath my desk here with tons of drawing and tons of pictures, and it's all on the endocannabinoid system. And I, you know, that's what I would do for an hour, is show them pictures, and just like a heart surgeon would show their people. And I think it works.
mhm,
You know, I mean, obviously everyone has different intellect. Obviously somebody has different, what they're good and not good about reading. But I do think that parents, you know, who want to learn, I mean, I think that's also important. Um, uh, I think we can. And I think that there's plenty of tables and pictures that you know, that we can do. I think the teens, a lot of the teens that I would see were actually dragging their moms and dads to me, you know, for help. And of course, you know, they're teens, and, you know, that's a whole nother discussion of what teens, you know, are good at or not good at, and what they should and shouldn't do. But they, you know, they were interested in seeking out, you know, and learning those types of things.
mhm,
I mean, look, if you ask me to describe to you what's going on in the nucleus and all the different receptors that are going across and all those complex exchanges that are taking place, I don't know all of that.
mhm,
I have to look it up just like anyone else. But I don't, that the parents don't need to know that. The parents need to understand what doors open and close, where the doors are, where the knobs are, why, you know, they don't need to know what a positive allosteric modulator is. They need to understand that things can walk backwards and make an action take place.
mhm.
And so I think that all those things, you know, can happen, and definitely in the pediatric patients, because more times than not, I feel like those parents, they're invested. They're
Mhm.
there, they want to learn, they care about their children, and that's why they're coming, you know, to see you or I.
Mhm.
Um, and so I think it definitely can be done.
Agreed. Um, so we're winding down. I think I'm not in too much of a time rush, but if you don't mind, we'll spend a couple more minutes.
Sure.
Um, so one of the questions I get most often, and I imagine you do too, is about brain damage for kids who are taking medical cannabis. Um, is it true? Are our kids becoming brain dead? Is there permanent damage? Are they not be able to learn? You know, all these kinds of things that people ask about. Do you get those questions, and how do you usually respond?
Yeah, I mean, the answer is we get those questions, as you know, every single day. Um, the data is skewed. The data is not consistent. And, you know, it's funny. I thought you were going to ask me a different type of question today. And there was a paper that came out this week in JAMA
Mhm.
Psychiatry about, they followed 11,000 something among pregnant mothers
Yeah.
who knew that they were pregnant, who didn't know that they were pregnant. Did they smoke cannabis? Did they take it? And it was retrospective, trying to guess as to what there are. That, although this study is great, like, do you really remember, you know, every sort of thing? But then this paper makes this ginormous comment that mothers who knew they were pregnant, who then used cannabis, now there's a higher incidence of psychotic like behavior, or, you know, all these other things. And so, but if you go back and look, you know, there was also a lot of history of other things going on, you know, in those families, or there was tobacco use, or there was depression. So, I mean, I guess what I'm saying is that there are definitely people who should not be using cannabis. There are definitely people who use cannabis and can have psychotic like episodes. There are definitely patients who use cannabis that for whatever reason can get brain damage. I personally can't tell you, and I've now been able to read that if you take X amount of people on a prospective level who have used cannabis, that they have brain damage. Now, the caveat to that is that the developing brain, you know, lasts for several years. You know, so if you take a newborn to the age of 5, you know, that brain is continuing to develop. What I don't know the answer to, and I don't think anyone does, is if they were, you know, if cannabis, if they were exposed to it, you know, what happens to those brains? But again, it's not like these are, this isn't a teenager going and, buying a bag from somebody and going and using it. I mean, again, we're talking about patients, from a medical perspective. So I don't know the answer. And I don't think that anyone really knows the answer. And I think it's multifactorial, and there's probably some other genetic factors that, that we've learned about. There's probably some perinatal factors that, we don't know. And I don't think everybody's honest when these questionnaires are always being formed. And so I don't think we have enough data. I think in the patients that we're talking about, I don't have any issue with it, as we've discussed. And again, we're talking about patients who are, for all intents and purposes, don't have, have serious medical problems.
Mm-hmm. So for those who are watching and curious, I've put together a free archive that's, well, certainly a free archive of all the cannabis data, but actually one that's specific, a folder that's specific to pediatrics. And I just put it in the chat. It's bit.ly/C, so seed, and then pediatrics data. I'm aware of the recent study. I'm also aware of 4 other studies that are longitudinal, looking at pregnant women and the effects on their children as they've grown up. And it's not looking as terrible. There's some gender-specific effects in emotional outbursts and sort of reactivity, but nothing as catastrophic as this sort of stories people are worried about. Things like, my kid's gonna be dumb or unable to succeed, or whatever.
Yeah, it's sort of like the example I give is I always say to the pediatric GI doctors, the gastroenterologist. I mean, they're at the end of the line, and everyone is coming there with abdominal pain, but the majority of kids express their frustration, concern, they internalize whatever it is, and abdominal pain is very common. And that and so they end up on medications, or they end up being seen for whatever it is, or getting MRIs, when half the time it's getting a better history, or having the child talk, or maybe they were touched, or whatever that might be. And it's the same sort of thing. I mean, you just gotta get more data.
I agree. To sort of, it's a little bit of an intense conversation. We'll ease back a little bit. Some of the contrarians who position themselves basically against recreational cannabis for children don't seem to distinguish between medical and recreational. What do you think? Is there a difference?
I mean, I think there's a difference, because I think the intent of a recreational use is to have a cerebral type effect. I guess I would equate that to somebody who comes home at the end of the day and wants to, have a little bit of a cocktail, and, because they had a bad day, and wants to just sort of, relax. To me, that's a recreational sort of use. From a medical perspective, I mean, I look at this as, I'm not coming home at the end of the day to have a drink to say, how's my endocannabinoid system doing? But when I'm looking at this aspect, I'm specifically asking, what's going on in this patient's endocannabinoid system, as best as I think I may or may not know, and how can we help manipulate this so that from a medical perspective, they have benefit. I don't think that's the same conversation from a recreational perspective.
Mm-hmm.
And again, when people talk recreational, I think they're only talking about THC. Mm-hmm. And when you're talking about medical cannabis, you and I is talking about that's 1/100th roughly of the conversation when we're talking about all the other cannabinoids. Mm-hmm. So, to me, it's apples and oranges, and it's a completely different talk. Mm-hmm. It's the same way I would have a conversation with you at a bar versus having a conversation with you, like this. Our goals are different, our intentions are different, and we're also talking about a real physiologic system. Yeah,
no, agreed. Okay, so there are 2 more questions from outside sources. We got one from LinkedIn, a comment and a question. The question is about Epidiolex, and when pediatric patients are denied insurance for Epidiolex, and for those who don't know, I think it's $35,000 a year for that medicine, right?
It's something in that range, yeah.
Which some insurances don't cover it. Do you suggest or recommend specific CBD formulations to fill the gap?
I mean, I do. I mean, I won't, for the sake of this conversation, say the companies that I sort of recommend, but I would say there's about 4 to 5 companies that I've either personally used, had tested, or had my patients use, that I think, fills 3 goals. 1, it's a good product as best as I know. 2, they release their testing as best as I think, and then I would have it tested. And then 3 is the price, because obviously, I'll just say in the state of Florida, the probably more than 75% of the patients are Medicaid patients. So a lot of these people can't afford these products. So yes, the answer is I would absolutely recommend those. A couple of the companies are very nice and gave me codes so that I can get to the patients, and then they would get a discount and yada yada. I'm sure they do the same thing for you. So yeah, I mean, and to be honest, if someone came to me and said, "What would you do?" The Epidiolex, or I would have the same conversation that we've had about it. And if their insurance is going to cover it, then then that's great. But I would tell them that I think you can achieve the same goal, without going through all the paperwork and getting a neurologist, a neurologist.
And this question is mostly useful, I think, for you and I to correct. So the comment on LinkedIn is, did you know that anyone under the age of puberty cannot be high? Did you see that comment?
I saw that. I saw it, yeah.
So they're claiming that the CB1 and CB2 receptors are not fully developed, and it was, unfortunately, I guess, Dr. Mashulam who said that. I don't know if that's true. I mean, I'm curious what your response is.
I mean, I guess my question is how do you ask, a prepubertal person, do you feel high from this? I mean, I'm trying not to sound dumb, but, I hate using that word, but I'm trying not to sound naive. But I'm going to make the assumption for the great and wonderful odds, Dr. Mashulam, because, is that he must have some physiologic understanding of how those receptors work, and that I don't know. And that I would assume that in mammals, his understanding is that those receptors are not, up to their full effect. So I mean, if it's because of that, then I would say, but I mean, I don't know how you ask that question outside of just describing what high might feel to a prepubertal patient.
Yeah, I mean, I think even if it were true, which I don't think, my hunch is that quote is not accurate. From what I know of Dr. Mashulam, he's very humble. He knows what he doesn't know, and I think on the one hand, how do you judge that in someone? Like, you can't really, that's not an outside thing to judge. Like, if someone feels euphoric, we don't have a measurement for that. And how would we judge that? And B, it's a little bit of a clinical, physiologic question. And maybe there's experience there in a petri dish or in a theoretical model, which is very different than the clinical reality. And more importantly, across the board, we do not all follow, whatever clock, we have. I think people develop differently, and I think it's hard to put everybody into a single box.
Yeah, I mean, I guess I would, just to be geeky, ask, well, are the GABA receptors fully, developed at that age? And all I can tell you is that you watch a 5-year-old with a compound fracture get a little Versed and they're giggling their head off while they're, you're setting their bones. So, I mean, I probably would describe them as high, but it's a different thing. So I think it's a great physiologic question. I just don't know the answer.
No, fair enough. Awesome. So before we sign off, I would be remiss, and I think the audience would also be remiss in this time of COVID, to have a little bit of a departure from the cannabis discussion, but to hear what your experience has been in the ICU with respect to pediatric patients in COVID.
Yeah, so I mean, I have found the past 3 months, probably next to cannabis in the last 4 years, it's sort of the most fascinating, where I've really felt like I was on the cutting edge of seeing something for the first time in my life. We have not had, knock on wood, any deaths in our institution from any pediatric COVID. We have had a lot of patients present, mostly who have been exposed to COVID, and because this is a whole talk in and of itself, but there's what's called MISC, which is multi-system multi-system inflammatory syndrome in children that we've been seeing post-COVID. And I'll spare everyone the details, but some of those kids have gotten really, really sick, and all of them have gotten better. I personally myself has placed 4 of them on breathing machines, meaning that we've intubated them, and within 72 hours, all of them have been extubated, and all of them have left the hospital pretty much back to where they are. We down here, there's 3 main, just for everyone's knowledge of geographic or from geography, there's 3 pretty main pediatric intensive care units down here in South Florida. And that we sort of, keep in contact with most of them. And I think maybe there's been one death that presented fairly, already pretty much in bad shape, but that was somebody who had significant, and if I'm quoting wrong, I apologize to the institution, but that was a patient with significant medical problems. So the answer is, in acute COVID, there's been very, very limited or little amount of patients that have come in, and that was mostly sort of in the beginning, and most of those patients came in with an oxygen requirement. That was what led them to come to the hospital. So similar to adults that came in, but of course adults that required oxygen, and then of course a lot of them ended up in the ICU. But during that whole time, we didn't see really much of anything. Mm-hmm. I would say starting in, it's now September, probably most of the summer, July and August, we saw a lot of, again, what's called MISC. We probably still get in our ICU, we have a 55-bed ICU, probably 3 to 5 a week, at least of this. It's a little bit downtrending, and it seems like they've been a little less severe. I would say about 80% of them have had what we call COVID antibodies, meaning that they've been exposed. Depending on the test, some of them still show that they're rapid COVID, which means that their acute COVID test is positive. But I think what we've been able to see is that these patients are shedding what's called RNA, which is in the nucleus of the virus, even though the virus might not be causing deleterious effects, because these patients also have antibodies, which is showing that they've been exposed. And you probably can't really have an acute illness and then have these what called IgG antibodies. The problem I think that we've all been having, and the same problem that that most people in the country and the world have been having, is what's the best way to go about treating them. And because this disease has been similar to something called Kawasaki's disease, which is common in less than 5-year-olds, the experts have done a lot of medications or treatment based on this disease. And that disease is not without its own difficulties and controversies. And so I think there's been a lot of patients that have gotten a lot of medications, and I don't think we'll know for a while what's worked and what's not worked. I sure don't know. I think that the majority of the kids just have, amazing immune systems, and I think just care in and of itself has gotten better. And a lot of these kids are coming to the hospital fairly quick. So it's real. We've definitely been seeing it. I've not, again, I'm not going to see any deaths. I've seen very completely normal patients get very sick related to COVID and then get better. But the majority, as I think most of the country has seen, Pediatrics has done fairly well. And I don't understand why. I mean, I think we can just say that their immune systems are better, but we can talk about the ACE receptors and where they are, but I don't think we know. So I think the next part is going to be exciting as things get controlled and all this data is put together.
Yeah, I agree. Yeah, and I think it's healthy and inspiring for us all, including me, to see an astute, very knowledgeable clinician who's been through untoward number of years in classes being able to say, I just don't know, and we're learning. I mean, we're human, and we're all trying to figure this out, whether it's COVID or cannabis. And our job, I think, as clinicians, is to be a consultant for patients, to be a reference. We're not gods. We're not masters of all. We are just hopefully well-informed and hopefully experienced with patients, and hopefully we can translate. Some of the job of what we're doing is just to translate what we know into patients so they can understand and make a decision.
Yeah. I mean, I guess I'll leave it by what I've seen that's pretty amazing is our numbers are down overall in admissions. And I think it's, COVID has opened the doors to the importance of hand washing, not coming to work when you're sick. I mean, for the last, I would say 5 years, has worn at least gloves if not a mask and gloves with every single patient that I go into the room, just because we're always changing and knock on wood, I rarely, if any, get ill, and it might be related to that. But, you know, kids aren't going to school when they're sick because there's been no school. Daycares have been closed. Adults have not been going to work because they're sick. And so that to me has been fascinating. I mean, in Florida, or especially South Florida, RSV, which is respiratory syncytial virus, which is very seasonal, we have all year round. I can't remember the last RSV positive patient that we've had in the past 4 to 6 months. And today I just admitted a bronchiolytic for probably, which is an inflammation of the tiny airways, which we see all the time here, every week. I think this is the first one that I've admitted in weeks to months. So
silver lining.
Yeah,
Okay.
The yin and yang.
Yeah, awesome. Well, thank you for spending so much time. Thanks to the audience for participating and joining us. We will definitely have you back because this is fascinating and we haven't touched on half the topics that I think we could. But certainly enough for tonight. And hopefully we'll see everybody who's here again. And if people have interest in learning more, you can always reach out to both Dr. Exelbert or I. We both have LinkedIn. We both have Twitter and email, and Seed Clinic, cedclinic.com is the way to get to either of us. All right. Thanks, everybody.
Thank you.